presentation, for this presentation, and I'm going to try to focus on these objectives. We're going to talk about the shift that we've had from a glucose-centric to a cardiometabolic focus in diabetes. We're going to talk about how we now are asked to design effective treatment approaches for high-risk patients with diabetes and its comorbidities. And then we really are going to focus a little bit on some of the limitations that are embedded in the clinical practice guidelines for type 2 diabetes, because there are some shortcomings with respect to the guidelines when it comes to high-risk minorities, but we'll talk about how we navigate through that. And then finally, we're going to spend time talking about the team approach that's required for successful management of diabetes with all of the elements: education, technologies, and community-based resources. Now, when we look at diabetes as a disease entity, notice that this map that you see here, which is basically the CDC's representation of the prevalence and distribution of diabetes in this country. When this data was started in the early 2000s, the only intense colors that represent high prevalence rates, as you see here in the 12 and higher prevalence rates, the only area in the country affected like that was in the southeastern United States. Excuse me. But now what you see is that by 2016, those numbers of intense high prevalence diabetes are virtually all over the United States. We've gone from 37 million in 2022. It's anticipated that at current trends, we'll reach over 55 million by 2030. Notice that as your population grows, if your prevalence rate of a disease is also increasing, that means that the numbers of people affected by that disease really goes up. Where is that growth occurring? Well, what we see is that some of the sharpest rates of growth of type 2 diabetes in this country are occurring in Black males and females, represented by these two top lines. It's growing in everybody, but some of the highest rates of growth are in Black males and females. It's no surprise then that as you look at the distribution of diabetes in terms of age-adjusted percentages across ethnic groups, that compared to the majority or the white population that you see over here, all of these other populations of color, including African Americans, have much higher rates of this disease. It doesn't stop there, because the risk factors for coronary disease and cardiovascular outcomes are higher in diabetes generally. When you see the rates of coronary heart disease, heart attacks, and any heart condition in people without diabetes in gray compared to those in red with diabetes, you see roughly twice the rates of cardiovascular outcomes in diabetes. So in addition to that, people with diabetes are 2 times more likely to die from cardiovascular related problems compared to those who don't have it. If you focus on populations of color, now if you look in this lower right-hand side of this graphic, what you see is that people of color are twice as likely to die from diabetes complications and almost 4 times more likely to have end-stage renal disease when we're talking about the African American population. So this is a major concern for us, okay? Because even when it comes to the use of technologies, Black Americans are 3 times less likely to use things like insulin pumps, CGM systems for glucose monitoring. We have some significant gaps. All of this relates to what happens with marginalized people. When we think about marginalized persons, the things that characterize such populations is that they are generally populations with less self-esteem, high poverty rates, high stress rates, and an increased load of the social determinants of health in terms of where they live, where they work, where they play. How do people get to such a state? Well, historically, you can get there by either being displaced through bondage. That's the American slave story. Or if we look to the north, in Canada, what we see is that people were displaced by virtue of oppression. The indigenous populations, the First Nation, Indians of Canada, were people who became marginalized because of oppression by colonial influences.
It's not coming.
I don't know, Queen, if you can hear, please mute yourself. Dr. Gavin, can you unmute?
Okay, I'm not sure what is happening here because I did not mute myself.
Yes, I'm so sorry. So everybody, if you could put all your microphones on mute. We had a couple people enter.
Okay, well okay. I'm going to try to keep going, but I'm not touching my mute button.
Okay, perfect. Thank you.
Okay, so we're talking about marginalized people, and one of the consequences of being marginalized is the fact that these are people with poor health, higher prevalence rates of chronic disease. And when we look at the mantra of marginalization, it's the wealth gap that drives the health gap. Now, I want to focus on the fact that it was Martin Luther King who said, of all forms of inequality, injustice in healthcare is the most shocking and inhumane. And this is why we need to be concerned, okay? We ask ourselves, how did we get here? Well, it's important when we talk about big diseases like diabetes to consider the historical context. There's both a historical, medical, and scientific context for health disparities that's important for us to understand if we're going to be able to work our way out of these enormous problems of disparities. In the United States, what started out as a dehumanization process of slavery, this is what gave rise to the disparities that we're dealing with today. Slaves were bought, sold, and traded. This is Main Street, Atlanta in the 1800s. And what you see here is a shop which advertises auction and Negro sales, because this is what we were. We were a commodity. And this is what started the dehumanization process in this country that led to the disparities of the day. We were considered property. And there was a legacy, and there is a legacy of this. Years later, after emancipation, this is during World War I. This is a photograph of the way Black soldiers were transported from the European front, coming back to the United States after having served in World War I, just like any other soldier. But look at this abominable set of conditions that you see. This is the legacy of having been dehumanized. So what we're seeing here is that there's been a litany of long, enduring elements of a bitter past that has given rise to the social and financial issues which have driven many of the socioeconomic and political and even health issues that affect us today. We're talking about coming out of slavery into Jim Crow, where there was now the tyranny of unregulated debt because of peonage. Slaves were no longer somebody's property, but the people who owned them were now their bosses. And this was a terrible situation. vagrancy laws were passed. People of color could be arrested for not having a job, and they were never given the preparations for having a job. Housing patterns of segregation. Remember, in 1917, the decision of Buchanan versus Worley, this was a Supreme Court decision which made it illegal for Blacks to live in areas where the predominant occupants were white. Okay? And so you could not live in majority communities. And then when we saw that Blacks were not able to get into the housing market during the time when that was the only way to get access to middle-class wealth, and how were all of these draconian separation processes maintained? Through violence. What you know is, and I won't go into all of this, but you know that there were many instances of white supervised, orchestrated violence. Massacres of one kind or another. Over 4,400 lynchings from 1865 to 1943. The wealth gap that came out of this bitter legacy is what has driven the health gap. Now, the historical patterns of discrimination, the eugenics theories that define certain ethnicities as biologically inferior. We saw the closure of medical schools, 10 medical schools that were were Black medical schools were closed during the Flexner report of the 1910s. It was estimated that over 35,000 additional physicians of color could have been produced had those schools continued to operate. We saw a deterioration of trust in the medical establishment, problems with communications, healthcare provider bias towards minority patients. All are legacies of this historical set of precedents that we had to deal with. Obviously, we had experimentation going on. J. Marion Sims experimenting on Black women without their consent. Why did they do that? Because the owner had to be the one to give the consent, not the slave. Okay, and we had, of course, downstream from that, subsequently things like the syphilis story. These are persistent problems, and our urgent challenge is to discern why have we come to where we are, because it's not unless we understand that, that's the only time that we can really get remedies to this problem. We need to understand how much of the differences that we see today is due to biology, how much is due to bias, how much of the differences in healthcare outcomes is due to behavior versus other factors. Well, let me say this. The differences in the behavior of a disease like diabetes has very little to do with changes that have occurred in our genes, okay? We should really be focusing on the elements of our environment and our behaviors, things that we can modify, because that's really where the greatest potential for change resides. I'm gonna give you one striking example of why we should focus on environment and behaviors as opposed to wasting time talking about genetic this and genetic that. Not that genes aren't important. Back in the early 1800s, the Pima Indians who lived in southern Arizona and northern Mexico and had been there since 300 BC, they were farmers. They took advantage of the water that was accessible from the Gila River, but then when the white settlers came, they dammed up the Gila River. The Pimas did not have a water source. They couldn't farm anymore. They had to establish a reservation. The Pima Indians were gathered onto the reservation in 1859. The first case of diabetes in the Pima Indians was recorded in 1908. About 30 years later, Elliot Joslin documented 21 cases of diabetes among the Pimas. Less than 20 years later, there was a 10-fold increase in the prevalence of diabetes among the Pimas. Why? Because now they were no longer agrarian. They were no longer growing corn and wheat and eating foods of the earth that they planted, fishing in the Gila River. Now they were eating government subsidized commodity products, lard, bacon, white flour, processed foods, and the prevalence of diabetes skyrocketed. The prevalence of diabetes was 46% among the Pimas by the 1970s. A number of Pimas at the time of the reservation was established, they left. They migrated to the mountains of northern Mexico, and they lived there. Now, these were not genetically different Pimas. They were the same Pimas who stayed on the reservation genetically. But 40 years later, the difference between the Pimas on the reservation and the Pimas in the mountains of northern Mexico, who were eking out subsistence living, were slimmer, were more active. There was an 8-fold lower prevalence in those Pimas who had migrated. They had markedly different diets, BMIs, physical activities, all because of environment and behavior, not because of changes in their genes. Our genes don't change in 40 years. And a similar story can be said of Japanese from Tokyo who settled in Seattle, but for the sake of time, I won't deal with that. A more pertinent story for us is the comparison that happened between a group of physicians who had graduated from Meharry versus a group of physicians who had graduated from Johns Hopkins. This was in the 1958 to 65 time frame. The all-Black cohort of graduates were compared to the all-white medical school graduates, and 25 years later, after being followed and compared in those two cohorts, the Black medical doctors were likely to have a higher risk of CVD, earlier onset of such disease, higher rates of diabetes and hypertension, higher incidence of coronary artery disease, and their case fatality rates for coronary disease and cardiovascular disease, 52 versus 9%. Okay? Now, they were not poor. In fact, the Black doctors were some of the most well-off people in their communities. But while they were free from poverty, they lived largely in Black communities because of segregation. They received their health care from persons who looked like themselves. The social determinants of health and environmental legacy, these are things that trump, if you will, genetic influences. So marginalization is an important driver, and we should never lose sight of the elements that constitute marginalization when it comes to some of the poor health outcomes from diseases like diabetes and others. Now, one of my mentees, Sharita Golden, who is a professor at Johns Hopkins and the chief diversity officer there, they've done a lot of interventions to see what can be done that could generate successful improved outcomes in diabetes. They've looked at elements of disease management, set up registries, use health information technology, IT, to track and monitor patients and change the care management programs. But one of the things that they found to be really important is the use of practice guidelines. Using guidelines can be a very powerful element in improving outcomes. Nikki Lurie and her colleagues years ago pointed out that improving quality of care through the use of practice guidelines can play an important role in addressing racial and ethnic disparities. Okay, so when we talk about guidelines, we're really talking about taking advantage of things that have already been generated by agencies like the ADA, ACE, and the American College of Physicians. Any organization that sets up guidelines will have a decision cycle that looks sort of like this. This is the one from the ADA, and they tell you what we are supposed to do. The first thing to do if we're going to achieve the goals of care for patients with chronic disease like diabetes, the first step is to assess the key patient characteristics. Who is this person sitting in front of us? Okay, their lifestyle, their comorbidities, what are their clinical characteristics, and what is their motivation, and what is their mental status? And the ADA has already started introducing cultural and socioeconomic issues so that social determinants of health have become important in the ADA's decision-making cycle. But what they've missed, and what you don't find in the narrative of the guidelines, they don't talk about population-specific information, that is, information relative to minority populations about efficacy and safety of some of the interventions that are being recommended. But the decision cycle is what we are supposed to use. What's been missing is how these elements apply to minority populations. Because if you look historically, all of our focus was on what? On glucose. The important issues related to kidney disease, cardiovascular disease, risk factors like lipids and blood pressure, those were peripheral considerations. Lifestyle. Glucose was the target for our efforts at controlling this disease. In fact, we tried all kinds of studies. We had one trial after another trial, trying to normalize glucose to see if that would change not only microvascular, but macrovascular outcomes as well. This was the ACCORD study, where over 10,000 patients with a median A1C of over 8 were treated intensively. The goal was to get their A1Cs to less than 6%, compared to standard therapy, where they targeted a goal of 7 to 7.9. Many of these patients got into this range of 6%, but what they found was that after years of follow-up, there was not much difference in the primary outcomes, that is, major adverse cardiovascular events, between the intensive, red, and standard, blue, treated groups. But look on the right side of this graph. There was actually slightly more mortality, death, in the intensive group. This raised an alarm, because it's clear that while you might prevent microvascular complications, macrovascular complications not only didn't go down, as you see here, there was now a signal of risk. And so what we've learned is that the answer isn't in normalizing glucose. But even when we were trying to normalize glucose as our gold standard of control, when you look at the studies that were done looking at African Americans using the glucocentric approach, the outcomes for A1C in African Americans were uniformly worse. So even when A1C was the goal, we still did worse compared to the majority population. And it didn't matter where the data came from. Cohort studies, clinical trials, meta-analyses, the African-American populations did worse. So we had a shift occurring. We were moving away from a glucose-centric focus to one that said, you know what, we need to look at something different. And it was a study, a small study that was done in Denmark that helped us with that. This was the Steno-2 trial. Now, this was a study less than 400 patients. High-risk patients, they were on intensive therapy that targeted all of their risk factors. And they were treated intensively for about 8 years. And when you look at that 8-year or so follow-up, there was really no significant difference. In fact, there was a tendency towards major improvement in the intensively treated group in that time frame, but only if you treated them with multifactorial interventions. If you continue to follow them for years, that is over 21 years later, notice that those people who had had multiple risk factors targeted, they had an 8-year longer lifespan. So intensive multifactorial treatment turned out to be the thing we needed to do. This changed the paradigm in diabetes. So we shifted from a glucose-centric to a cardiometabolic focus. Lipids and blood pressure and other risk factors became much more important as targets in diabetes if we were going to change macrovascular outcomes, kidney, heart failure, cardiovascular disease. So this now meant that cardiometabolic disease was the real problem that we needed to focus on. Now that means that we have to change our understanding of what it is we're dealing with. Well, with diabetes, you're dealing with disorders of the cardiorenal metabolic system. You're not dealing with just one problem. It's not just the pancreas. It's not just the anything. It's multiple organ systems. The heart is involved. The kidneys are involved. And the metabolic organs, the gut, the pancreas, the liver, are all involved. Kidney disease affects more than 40% of type 2 patients. More than 50% of type 2 patients are at high risk for developing cardiovascular disease. And over a third of kidney disease patients have concomitant heart disease or cardiovascular disease. Where you see one problem in this cardiorenal metabolic universe, you should look for another, because they travel together. And this is why guidelines-directed medical therapy has now become such a promising approach to interrupting the cycle of bad outcomes. Because in guidelines-directed therapy, you treat specific risk factors. That's what helps you to improve outcomes in cardiovascular disease, heart failure, and kidney disease. The treatments are designed to reduce the risk of cardiometabolic and renal dysfunction. Doesn't matter what your A1C is. That doesn't mean that the A1C is not important. It's just that your A1C doesn't become your gold standard for whether or not you're treating this patient in the most effective or optimal way. Now, why did we get to this shift? Well, because we had outcomes studies. We had randomized controlled trials that showed how the use of certain medications and certain technologies that lowered glucose could reduce microvascular outcomes, but they didn't reduce macrovascular events. The re-stratification that we've had to make diabetes a cardiorenal metabolic disease has come from a different set of outcomes trials that have changed our focus. Problem is, those outcome studies have basically given us results that everybody assumes are one size fits all. And that's a problem, because that's an assumption that isn't actually justified by the weight of the evidence. Now, it's the CVOTs that have provided the evidence base that is the foundation for our guidelines-directed therapies. That's what the ADA, ACE, and all of the other organizations have used. But the shortcomings, which I'll talk about here in a second, the shortcomings of one size fits all will have its greatest impact on minority populations. Because what we now have is a system of approach that says, listen, glucose is important, but in type 2 diabetes, if your goal is to change cardiovascular, heart failure, kidney disease outcomes, you've got to use the information that we've gotten from these outcomes trials. You've got to treat risk factors like blood pressure and lipids. You've got to focus on things like obesity and lifestyle in order, no matter what the glucose is, in order to change these cardiovascular outcomes. When we look at why this is so urgent for minority populations, and I'm just going to focus on African Americans for a second, look at the difference in the hazard ratios for Blacks compared to whites when it comes to all-cause mortality. We are at higher risk, whether we use adjusted or unadjusted numbers. We have higher rates of all-cause mortality. We have lower rates of mortality from malignancies, interestingly enough. But for cardiovascular mortalities, our rates are higher. And I won't focus on other diseases. But this is why when it comes to a disease like diabetes, where the risk for cardiovascular outcomes is so much higher, we have to be specifically focused on doing those things that are necessary to move the needle for minority populations. Well, what does that mean when it comes to this new re-stratification of our understanding about treating diabetes? What that re-stratification process looks like is this. It says that now the first thing we need to do when a patient comes in with type 2 diabetes, we need to see what's that patient's comorbidities. Do they have risk factors for cardiovascular disease? Do they have established cardiovascular problems already or kidney disease? If they're there, they need to be addressed concomitantly. That is, concurrently. All of those things need to be looked at. Yes, you put the patient on guidelines-directed therapies to lower their blood pressure, their lipids, you improve their lifestyles, but you've got to do something about those comorbidities that you've assessed from the beginning. This is when the new interventions become so important. This is when the GLP-1s and the SGLT2 inhibitors take on extremely high priority in our intervention strategy. The problem is that there's a question. And the question is, what is the role of these clinical guidelines that are now advocating for these new forms of intervention? What is their role when it's related to a specific population? Is there specific population-based evidence of effectiveness of these therapies rather than simply assuming that there's broad-based efficacy, that one size fits all? How valid is that assumption? Well, if we look at what's in the guidelines now, and this is a busy algorithm here, but we're going to peel it apart. At the very top of this treatment guideline, it says the first thing you do once you've made the diagnosis of diabetes, you put in place guidelines for healthy lifestyle, self-management, education, all of the things that speak to social determinants of health. All of those things have to be taken into consideration. But step one, after the diagnosis has been made, assess what the comorbidities are. Is there ASCVD? Now, this has been defined differently across all of these different outcomes trials, but you know, we're talking about TIAs, unstable angina, heart attacks, strokes, any revascularization procedure? Are there evidences of high risk? Are they an older population? Do they have underlying risk factors, hypertension, obesity, smoking, dyslipidemia, albuminuria? If any of these are present, high risk or present, or the presence of ASCVD, you need to put them on a GLP-1 or an SGLT2 inhibitor that has proven benefit. That's step number one. Yes, you're going to be treating the diabetes because these are diabetes medicines, but your A1C is not your major driver here. What you're dealing with is first and foremost the things that are going to kill them, and those are the underlying cardiovascular risk. Now, because it is a diabetes medicine that you're treating them with, I call them diabetes medicines with benefits. If the A1C still remains above target after you've started one of these agents, the guidelines are saying, well, you need to now consider adding the other, or adding some agent that's going to give you additional benefit for reducing their cardiovascular risk. I was at a guidelines conference several weeks ago, and the Europeans are already advocating that the SGLT2 inhibitors and the GLP-1 receptor agonists should be started simultaneously. So they are moving rather rapidly along this new paradigm. What about heart failure? This is a big issue now with diabetes because it turns out that the incident rate of heart failure is higher than the incident rate of myocardial infarction in people with heart attacks, with diabetes. So if a person has symptoms of heart failure or documented HFrEF or HFpEF, reserved ejection fraction or reduced ejection fraction heart failure, it doesn't matter. They need to be on an SGLT2 inhibitor. That's no question about it. CKD travels with heart problems. If the eGFR is less than 60, you're talking about people with stage 3 kidney disease. If there's any degree of albuminuria, you need to be, these people need to be treated for that underlying set of problems. They need to be on the maximally tolerated doses of ACEs or ARBs, and they need to be on an SGLT2 inhibitor, or if they have some problem with that, a GLP-1 receptor agonist with proven CVD benefit. And remember, there was a recent trial of the GLP-1, a kidney trial, that was stopped early because of benefit. We don't know what the FDA is going to do with that, but it may very well be that there may soon be a GLP-1 that has a renal indication along with these SGLT2 inhibitors. We talk about kidney disease so much because it is an enormous burden in diabetes. What we know is that there are 2 ways that you can get a progression of risk towards end-stage renal disease. And those we see on the x-axis here, that is albuminuria, and on the y-axis, glomerular filtration rates. And KDIGO, the Global Kidney Disease Organization, has put together this heat map, which basically says you need to assess both things in people who are at risk for kidney disease. You need to know what their eGFR is, and you need to know what their level of protein excretion is, because you need to know where these things intersect, because that's what tells you how high their risk is and what your treatment decisions ought to look like. So we see that the higher, the lower your eGFR, the higher your risk is. Doesn't matter what your protein excretion rates are. But if you look at people with normal or high eGFRs, their risk is proportionate to how much protein excretion they have. So you need to know both things to know where a patient's risk is, because albuminuria defines what the structural damage is to the kidneys. And when you look at this heat map in a slightly different way, now you see the intersection of their albuminuria and their EGFR, and it tells you what you ought to be doing. If you're in this range of EGFR and proteinuria, then you can be fine by just screening them. But now, when their albumin levels go up a little bit higher, even at these somewhat favorable EGFRs, they need to be treated. These are people that need to be on ACEs and ARBs. They need to be on whatever other medications are appropriate. By the time those same people are at higher levels of protein excretion, you need to be referring them. Yes, you continue to treat them, but you need to have the input of a nephrologist. And that same kind of paradigm is true across this heat map. The lower the EGFR, the higher the protein excretion, you need to be treating and you need to be referring earlier and earlier. This is the only way we're going to, on top of CKD, which is so important in diabetes. Now, when it look at CKD screening, you should be measuring albumin excretion. You should be looking at creatinine rates, assessing EGFR. And when we look at how this plays out, the percentage of adults with CKD and diabetes who are on blood pressure lowering medications, you see that by age, they're comparable populations in the middle age group and in the older population. They're comparable prevalence rates by age, by sex, by gender, men and women. But when you look at race and ethnicity, African Americans have by far the higher rates of prevalence of CKD requiring blood pressure lowering. So we are at much. It brings us back to this new stratification process that we are dealing with in treating diabetes. The question that remains, what is the role of these new guidelines when it comes to providing specific population evidence for effectiveness? Should we just accept the assumption that there's broad-based efficacy, that it's good for everybody? How urgent is the use of these medicines for high-risk populations like African Americans? Excuse me, I'm going to say to you, first thing we have to do is trust the science. When we live in a high-risk population like we have, what I can tell you is that the highest risk groups must take advantage of this powerful science that now is known about these GLP-1 receptor agonists, and that's what's represented in these sort of purplish boxes. You see the many areas of effects that they have in the GI tract and on the brain. The SGLT2 inhibitors, where you see these sort of bluish boxes, they have effects on the kidneys, they have effects on the heart, and in many instances, they have combined effects that you see in these pink-colored boxes. These agents have a well-established and powerful science in their mechanism of action. But when you look at the outcome studies, the trials that have been done, we see a variety of outcomes that have been studied with all of these different agents, and they show benefit. And the degree of benefit is variable, but the fact is that there is, as I'll show you in a minute, a lack of demonstrated evidence for this kind of efficacy, overall efficacy, in African American patients. But does that mean that we shouldn't use these agents? Oh, no. The science is what we need to trust right now. And so my answer is, should we use these agents in high-risk populations like African Americans? Absolutely, okay? Because the indications that they have achieved have been broadly expanded. The SGLT2 inhibitors are now not only indicated for diabetes, that indication isn't even on this chart, This is the expanded indications to reduce heart disease, established in patients with established CVD. All of these agents now have indications to reduce the risk of kidney disease and hospitalization for heart failure. And remember that in September, empagliflozin had its indication granted for reducing kidney disease. So we have broad-based indications for improved outcomes with these SGLT2 inhibitors. So in light of that, when we look at these meta-analyses on the impact of SGLT2 inhibitors in minority populations, and I'm focusing here on African Americans, what we see is that this forest plot shows that basically compared to these other populations, the trend for African Americans is towards no clinical impact. That's not so encouraging, but be cautious because we see wide variability and we see small numbers. And that's what confounds these results, okay? Now, what we know is that if you have patients like African Americans where the prevalence of kidney disease is so high, you need to intervene early and you need to intervene often. And what KDIGO says is that your first line drug treatment in these patients should include, yes, agents like statins and RAS blockade, that is mineralocorticoid and ACE and ARBs and mineralocorticoid inhibitors, but you need to be putting these people on SGLT2 inhibitors. First line, okay? All of this is on top of lifestyle, of course, but first line drug treatment now for these patients, and if they have type 2 diabetes, metformin and SGLT2 inhibitors, in addition to these other therapies, are recommended. So clearly, high-risk patients like African Americans, you need to intensify the therapy to make sure that those treatments are in place. Heart failure travels hand in glove with kidney disease. People who are at risk for heart failure, you need to have these people treated with these agents that have been shown to have highly beneficial effects on reducing heart failure outcomes. What are the pillars? You need to have them on an SGLT2 inhibitors, mineralocorticoid agonists. The newest one, Corindia, finerenone, has had phenomenal results. Beta blockers, ARNIs, all of these are the pillars of treating people with heart failure and type 2 diabetes. This is now highly recommended as part of the new strategy. I said earlier, heart failure is such a big player in diabetes because the incident rate of heart failure shown in red at any duration of diabetes, short duration or long years of duration, you see higher incident rates of heart failure than you do incident rates of myocardial infarction. So we have to take heart failure much more seriously in such populations. And it doesn't stop there. The atherosclerosis risk in community studies that studied large numbers of African Americans who had risk factors for atherosclerosis. Remember what those data showed, that when it came to those persons who had diabetes, that the presence of heart failure was higher in African Americans by a considerable degree compared to Caucasians. Diabetes was the most important determinant for driving heart failure as an outcome. And it's absolutely true that when you see in this dotted line the development of heart failure without kidney disease, you see that, yes, it goes up. But if you don't have kidney disease, you see that there's no increase in the rate of formation of HFrEF or HFpEF. On the other hand, if you have kidney disease, both your rates of reduced ejection fraction and preserved ejection heart failure go up. This is an urgent problem in high-risk populations like African Americans. And so there's a compelling need to consider the early and often use of these new strategies, despite the concerns that we might have about the guidelines right now. The GLP-1s, I'll say very quickly, same story. They've had an expanded set of indications. It's not just for treating diabetes anymore. They are shown to have benefit in the treatment of heart disease outcomes and increasingly heart failure and kidney disease outcomes. When we look at the GLP-1 impact in high-risk minorities studied in randomized controlled trials, again, if we just focus on Black, we see that there is a lot of variability. The certainty of their clinical impact is confounded by the wide variability and the small numbers. But we have to trust the science, okay? What we know is that we need multifactorial comprehensive treatment for high-risk patients like those that we see. We don't want to do any harm. So using these kinds of agents, which have low risk for hypoglycemia, makes them important in the treatment of their diabetes. Optimizing their treatment goals, managing their comorbidities, which is what we're trying to do, individualizing their treatment to accommodate their cardiovascular risk factors, extremely important. That's why a collaborative approach is essential. Primary care provider is the navigator, but the patient is at the center. It's got to be the captain, because this is where the cardiorenal metabolic problem lives. And we have to make sure that all of these voices, all of this expertise operates in concert at the appropriate time, in the appropriate way, to make sure that all of these outcomes are achieved in an optimal way. A multidisciplinary way is the only way to do it, and the evidence is powerful. This is data on cardiovascular outcomes in a traditional care setting versus a setting where there was a multidisciplinary approach. There was a 52% lower incidence rate of cardiovascular disease outcomes. The multidisciplinary approach works. This was a diabetes kidney disease clinic where you had all of these different sets of expertise working on the team. Notice that this kind of approach resulted in, this is just over in a follow-up period of a year, there was a lowering of A1C, an improvement in blood pressure, and an improvement in albumin excretion rates. This progression to stage 5 chronic kidney disease was reduced by 45% using this approach. What you have access to in the greater Atlanta area is a creative approach that actually helps to operationalize this multifactorial, multidisciplinary approach. You have this HOV MD mobile medical clinic approach that really takes advantage of the fact that you need multiple kinds of interventions. You need medication management, refills, but you also need lifestyle changes. You need the benefit of monitoring. And yes, you need to bring healthcare to people where they live, where they work. And this is one of the things that can be done using a creative approach like this. And one hopes that this is a model that will take wings and fly as a tool to be leveraged by local resources. So learning stuff about what creates disparities. The only way we can take advantage of learning stuff is because when you know what causes the barriers, you learn what you need to do to get rid of them. And what I would show you in this last couple of slides is that clinical inertia needs to go. You need to start earlier. You need to start more intensive therapy sooner in high-risk patients. Go down here to the underrepresentation of minorities in clinical trials. Yes, that has caused a problem because the data that we have from these outcomes trials is called into question because we have such low numbers. But we have to trust the science. But now, by using these agents and getting real world evidence from our observations of these outcomes, we can make a contribution. We can now use the response of our patients essentially as answering a research question. Real world evidence matters, and we are in a position to generate that. We'll need a lot of policy change, and we'll need to have a whole lot of focus on the social determinant of health. There's an urgency for these new strategies. There is the fact that this is a disease that reflects the interplay between all of the things that we've talked about: genetics, social history, environment. The risk burden is higher and more prevalent in our population, much earlier onset. Social determinants play an important role. We saw the study of those doctors. They weren't poor, but the fact is that they were subject to the same social determinants as anybody else back in those days. And so we have to pay attention to that. We need urgently this collaborative model of care, and we need creative strategies for better care delivery. This is what it's going to take. We have to be aware of what the risks are for marginalized persons. We need to know what that history is, what has gotten us here. We have guidelines that are based on powerful evidence, but we can't yet be assured that one size fits all. We have an obligation to try to augment the evidence base that is driving the clinical guidelines, to make sure that what we see in the use of these newer agents is broadly rigorous, that it applies to our populations as well as it does to those that have a stronger evidence base. We need to strengthen and broaden the use of the collaborative care strategies that have been shown to be so powerful. And remember, we have the opportunity to collect real world evidence in whatever happened. I'll just say it and then I'm done. We have to collect real world evidence, because by seeing what your patient's response is, you now have a way of generating evidence that we will never get from clinical trials. But when we collect that data and organize it, it's a research opportunity that we can generate and actually make as a unique contribution. And all of those things are going to be necessary to make this approach work in these highest risk groups. So I know we've gone on a bit, but a lot of information. And Lenore, I'm going to stop here. My voice is failing. And